It's difficult to do, but it's one of the things that I think you can only do when you're surrounded by other people who are like-minded and make space or push you to actually use your voice, use your language, much like the LLMs, to come up with an opinion, to say it and make it real. And in college, I learned about Wittgenstein's Beetlebox problem, and I always use that. You understand the world as you see it, but it's walled off from everyone. And the only way to engage and to help each other understand it is by engaging in communication and using your voice. So I find it's very, very important to be out there doing this. So thank you for making space.
This is the Visible Voices podcast. I'm your host, Dr. Resa E. Lewis. Audience, today's conversation is one in the series of episodes that we're doing on AI and healthcare. AI is either going to revolutionize medicine or it's going to make us all nostalgic for the good old days of paper charts. My guest is Dr. Christian Rose. Christian is an emergency medicine physician specializing in the broad intersection of clinical medicine, informatics, and innovation. Specifically, he looks at machine learning, decision support, user-centered design, and global health. Christian's been thinking deeply about AI since college when he studied the sociology of science. He earned the inaugural Donald Lindbergh Award for Medical Informatics at Columbia University, where he completed medical school. He's worked on global health telemedical services and emergency decision support tools with the World Health Organization in South Africa and Tanzania, and on the MacArthur Foundation's Human Diagnosis Project. Christian, welcome to the Visible Voices podcast.
Hi, Resa. Thank you so much for having me. So glad to be here.
Really glad to have you. So I recently read this headline: Generative AI uncovers undetected bird flu exposure risks in Maryland emergency departments. So this actually literally came out August 2025. And it was super interesting to me, and I want to get your thoughts on it. The scientists, the researchers, used a generative AI large language model. And they analyzed over 13 visits to emergency departments in the University of Maryland system. And it was looking at adults from 2024 who presented with acute respiratory illness, i.e. cough, fever, congestion. And using that model, they sought to assess how well generative AI could find high-risk patients for the bird flu. And the large language model looked at the high-risk exposures in patients such as butchers working on a farm with livestock, chickens, cows, etc. So the model identified 14 patients, and it's a little bit of the needle in a haystack cases among all the thousands of patients treated. And I'm wondering what you think of this sort of proof of concept, and also how it really does illustrate where we are with generative AI and predictive models for patient care.
I think one of the exciting next levels to this that we've been thinking about in our lab is ambient scribes. And I bring that up mostly because I think there's the version of using large language models as one subset of a form of artificial intelligence to scrape and review large amounts of data, and to even go between types of data like continuous monitoring data, radiographs, notes, and find connections that sometimes is the gestalt of what we do as physicians, that like, oh, there's a little schmutz on that x-ray. I don't have a word for it, but I think this in the setting of this person coming from a farm, I'm thinking like an atypical pneumonia maybe. So we do these things all the time, and the science and the artificial intelligence models, the language models specifically, try to sort through, multidimensional vector space to look for connections that might not be intuitive to us. And that's sort of the discovery part. It might look for things that humans might not notice, or it looks for things that we might otherwise miss because we are told when you hear hoofbeats, think horses and not zebras. And so you usually have some sort of trade-off when you're trying to see a patient, which is, do I go common things are common and treat them like the 80-20 rule? Most people will be a normal pneumonia and not a bird flu pneumonia. Or do you go, I need to keep digging down for this person? When do you choose to close and when do you not? The models essentially are a great way to look for stuff we might have overlooked, or maybe those were the 20% of cases that we said, hey, they might be coming from a farm, or, like working on at a barn or on a farm, and maybe they had high risk, but it's not really relevant maybe to whatever they're presenting with at the moment. So it's a good use of a language model to look through and catch things we might have let drop or spill, or the patients we might have overlooked, which happens in medicine, and we know and expect some failure rate. But language models are a good way to pick that up. The next part is, Well, did you even put those risk factors in the note in the first place? Because it can't
Mhm.
find what you didn't put in there. Maybe a different doctor noted, maybe their primary care provider wrote, oh, this is, a great 43-year-old who works, in animal husbandry. And they got that information and you didn't. And then that note from the PCP is used in a language model to let the ED physician know, hey, by the way, just want to let you know, this person might have had exposure to birds, chickens, whatever. So that's one of those versions where I'm like, the model is great to find the things we might overlook, to piece together notes from all different places, which I just can't have access to. But then there's also the element of using the same tools to record my conversation to let me have a normal human conversation and catch all of the stuff that I might have missed. So, one of the things we're looking at is whether or not these notes have greater social determinant of health information. Because when I just talk to a patient, and I have a great conversation, sometimes their job comes up in relation to why they have an ankle sprain or they pulled their back. Does that always make it into my note? Not really when I'm busy and trying to see 4 people in a row. So it's one of those ways that the AI can also offload from us the cognitive work of holding these important pieces of information that have to be used for future decision making.
So, readers, listeners, watchers aren't familiar with your work. Can you walk us through the work you're doing in your AI lab at Stanford?
When I think of these things, I have been doing some level of informatics work since my junior year, senior year in college when I was doing STS, Science, Technology, and Society, and got interested in for my senior thesis remote care because I just wanted to talk about NASA, like space medicine. And it turned out, training physicians, of which emergency physicians have gone to space, but training people in medical procedures at a distance is something DARPA and NASA worked on for a long time. When I went to medical school, there was, a post put out to learn a little bit more about, or, find places for students that wanted to learn more about telemedicine, but also molecular biophysics. My other major in college was physics. So my ears perked up. And I was essentially the only student that went and responded to this message, at least in my med school year. And I love my med school classmates, but they might have been preoccupied with other things. So I went and started looking at a bunch of the different projects at the Columbia Department of Biomedical Informatics. And already they had things like chat rooms for breast cancer patients and trying to do a natural language processing on sort of moods and tone of discussions. And they were doing, mining the EHR for kidney disease patients. This is 2008. And then they also had projects around alert fatigue. The EHR, the High Tech Act 2008 hadn't even occurred yet, but they were already aware of the fact that physicians were using the EHR at Columbia and hated clicking through all the alerts that came up that told them to do something very important and to prevent a very important potential drug interaction, but they just would close every one of those boxes and do whatever they were going to do anyway.
I'm gonna jump in and just for the audience, so the electronic health record is the EHR, what you've been referencing. And to your point, everybody thought this was like the solution to all of the challenges in the clinical environment for the clinician, for the patient. It was going to be this wealth of information. But the question is, how do we mine through all this wealth of information and organize it so that it's accessible at the point of care? For example, in the emergency department when we need to take care of patients.
If it can be so hard to navigate a useful technology, we have to understand how humans are using it at the point of care and what impact it ultimately has on them. Because you can give someone a perfect tool that will always catch, every possible error, but if they don't use it or it interrupts their ability to provide care for the other person next to them, it can ultimately have at scale detrimental effects. It can lead to burnout, it can lead to decreased focus, and you won't be able to actually see the benefits of the tool. Much like cancer therapeutic drugs and side effects, any intervention can have some level of potential side effect, and that's unintended. So, our lab essentially works on not only the science of artificial intelligence and how to use it to deliver better care, we also try to understand how it can be used inappropriately, how it can make accidents of like ordering too many tests, sort of what will happen if you deploy AI systems at scale. Their
Mhm.
sycophancy, their desire to just tell people, sure, yeah, you should get a CT scan of your head. You
Yeah.
should get antibiotics for that sore throat because they're trying to make the end receiver feel good about the interaction. That's ingrained in how they're trained, unfortunately. Go
I
on.
was gonna say, I have an example of that. So, I was, looking to see if there was ultrasound, publications, on a specific aspect, and, generative AI came out with all these articles that were published, and then I went to look them up, and truly, they actually were not real articles. What do you think about the accuracy and the reliability of generative AI in these medical searches right now?
Yeah. It's really difficult to do something that you have confidence in from an out of the box large language model for a very specific task. And most AI is like this. You need to train something for a specific task. Some people might have used something like Open Evidence, which is like an LLM that's then tailored only to medical literature. So you go, okay, this is going to be good at the medical literature. Would I use it now to tell me about the history of baseball? Maybe not. But the out of the box LLM, GPT, Claude, any of these are going to be really good at, for the most part, giving you a pretty good summary. They create a vector through and look for the average line and the right way to sort of navigate to the information it thinks you need and give you back what it believes to be accurate responses. There are all sorts of ways of addressing and improving the hallucinations that you're talking about, the sort of, hey, I got 3 actual papers and I got 1 out of the blue that's totally fake. Well, from my prior research from med school, it turns out you only need 1 in 10 wrong alerts to make you distrust the whole thing to begin with.
Right.
So that
Right.
goes back to that's again, AI, we think it's all new and we're trying to understand it. But from the alert literature, if you get fed one thing that is not accurate to the patient you're seeing, you begin to distrust and pause when you look at the system. That could be healthy, but it also means these ideas that we have of how this is going to change all of medicine and immediately you're going to get the most accurate information. There are questions about it because 80% right might not be enough for us. Sometimes it is okay and it's enough to get you in the right direction, but we have to learn how to interpret that, how to be able to use that information to dig deeper, and then how to validate.
You referenced actually that, AI is not just this period, this era, this decade. In fact, you've taught me about maybe there have been three major eras of AI. And I'm wondering if you can briefly walk the audience through that.
Yeah, this is widely considered by most informaticists in history of medical science people to be the third third hype cycle of AI in medicine. In the 60s, we had recommendation systems and expert systems that tried to, look, you'd program into the computer in these early days, this is what a white blood cell count of this must mean X, Y, and Z. And you'd start to program less. It was artificial intelligence because all of this sort of is any logistic or linear regression is a form of artificial intelligence and machine learning. But you had that early wave. People were like, oh, so we have now data to support medical gestalt. That sort of fizzled out because there wasn't computational power to do sort of anything in medicine, which was tough. Then in the 80s and 90s, you had a second wave. You're having finance people start to do modeling on social dynamics and the markets. And people said, ooh, can't we do that in medicine too? Can we start modeling and predicting what's going to happen with people? They went to go try and do it. And it turned out at that time, the sort of limiting factor, because personal computers and computation was growing well, that their limitation was data. And they didn't have enough data to make all these decisions or predictions off of necessarily for the wealth of problems in medicine. So, cut to the third one, post High Tech Act, post us going, okay, we need better data. Those paper notes can never be used for any future research because no one can find them.
Or read
Doctors
the
start.
handwriting.
Yeah, exactly. You don't know what happened there. You believe someone came to the hospital and left, and other than that, it's all very gray. And then you're like, okay, let's make the EHR. The EHRs had all these negative repercussions, but I often say the silver lining was that it has provided the basis of us writing our logic, having machine interpretable and human interpretable information to start working off of. And now we have the models. So there's the compute, the data, and the models for the growth of AI. Finally, compute isn't the major issue in medicine. The data isn't the major issue. And now it's the models have grown and have, since GPT, these preformed transformers and pre-trained transformers have become, hugely powerful and general enough to apply to many different problems. So we'll see how this goes, but it's been always a different thing.
Yeah, I love the historical walkthrough and also sort of this putting it into perspective where we are in AI. So, you and I have participated and partnered with healthcare organizations and colleagues across the United States and across the world. I mentioned Tanzania, South Africa with some of your work. So, what about AI? Like, is it going to be something that widens the gap between rich and poor healthcare? Point of care ultrasound, the feeling is that that can help level the playing field. What are your thoughts about AI?
I, yeah. far be it for me to not just be like, I have a lot of thoughts. Let's go into my usual cautiously optimistic. I think I've told you I'm the middle child and I have this sort of classic emergency physician. I'm prepared for the worst, but I'm hoping for the best in any of these scenarios. When I was doing my initial global health work in medical school, it was about access. And the return was, well, there's a lot of people who live many miles away who cannot get to a hospital in the first place or get basic level healthcare because of rural and infrastructures and even road and like literal infrastructure that prevents people from being able to access healthcare. Okay, one solution to that is you should build better roads and do some of the big projects that help modernize places. But that's not actually meeting people where they're at. And technology, it has turned out, many of these advanced or like leading edge technologies can have the biggest impact in places where they don't already have a sort of the systematic inertia on like the American EHR side, where we made some investments. We're looking to use these tools. When you go to some place that has no a priori assumptions and you say, well, what is it you need and what's the right technology to support that? Access, like telemedicine, was a huge one for directly observed therapies, calling people who had cell phones to check in about their symptoms and for tracking of infectious disease. It was just simply not done. So very low hanging fruit technologies helped with that. Artificial intelligence offers another one where you're saying, okay, across the world, the WHO says we have, a doctor shortage in the millions. And the demand for healthcare continues up and to the right. It might have like almost no limit, especially with an aging population. The demand for healthcare services across the globe is massive. Well, number of physicians stays about the same, and we've hit our upper limit of how many people we can see. So will AI help narrow the gap between the demand and the supply mismatch? Or will it also lead to people essentially, okay, because of that, only certain people are going to get the human, like when you call in on like to fix a flight. I've gone through all of the mechanical one now, and now I've fallen out. Will everyone essentially like hit that limit, and then some people will or will not have access? If the goal is just getting people something better than zero, which you'll hear Sam Altman, you'll hear a lot of the tech leaders say, like, this is a straw man argument, and we're talking about people who have almost no medical expertise, accessibility, and we can train one regional doctor to have all of the world's skills, in a clinic in Malawi. That is a very reasonable and hugely important impact of this technology. How it looks in the US might wind up being you never get fed to the hospital in the first place if you haven't paid to play. And that's a real concern some people have, that, oh, the haves and the have nots will continue, much like everything else in the economy. Some people will get a digital version of a doctor at the same price they've been paying for, and other people will get the actual representative on the line. Real outcomes, but they're just from very different ends of what your hope is. And I don't know how to decide which one's right.
What is one thing about AI that, we haven't even imagined yet in terms of how it's going to affect how we train doctors?
There's there's just so much in the training of doctors realm that's sort of blowing up. I think very reasonably the education space with this version of artificial intelligence around large language models have become so. There's a reason we're all talking about it, and every medical school is trying to assess this, because this is a general use technology to separate it from things like 10 years ago's AI, which was Christian or someone created a model to predict sepsis in this one person. You couldn't really interact with it. You had to get it in your specific EHR, and the result would be a little flag. Now you get information in narrative form, in conversational tone, that everyone from a child, anyone who can understand language or type or even just speak to an agent can get. We talked about a lot of the other parts of education and sorting of information. I think the question that I keep having is more around what has been the role of the physician in all of this. I get really worried that when people talk about medical education, again, I'll go back to the sort of history of medicine. You had the formation of the AMA around the turn of the century. You had snake oil salesmen, people telling you what medicine looked like and how they would heal you. There's a real risk we run to that again. And so you had medical foundations and medical schools deciding what was like truth and what's accurate information, what do you need to know to become a doctor. The way that has transpired and taken form in medical schools across the country is different and looked different 1900 versus 2025. I think we have to think a lot, this metacognition, about the physician's role as advocate, as caregiver. So much of the discussion right now is just around knowledge and medical knowledge. And we know that the exam scores do not predict the quality of your care on your patients. Sitting me down and asking me to take a multiple choice exam that I may or may not be paying attention to, I might just be looking to pass, doesn't determine whether or not my patients like me, have good outcomes, I avoid medical errors. It's just a knowledge test. These are great knowledge machines. So dumbing down or consolidating all of what medical school is into a series of you were taught the information in the textbook is just not. It is devalues what we do. It overly reduces the complexities of how healthcare is delivered and leaves us in a place of just being a knowledge worker and not a healthcare professional and physician, which again has looked different in Greek times than now. So I'm hoping that the medical schools and everyone, ourselves, because we're part of this, will actually think much more critically about what does it mean to be a physician in the modern age? Is that helping people navigate? And one specific question we have in our lab is that saying no to people or telling them you can't always get what you want? We have to talk about what the system and your individual needs and hopes are. You can't just go into the machine and have it tell you exactly what it is you want to be told.
And when you,
And so that's
just to
where I am.
clarify, you can't always get what you want, meaning in terms of the information or in terms of like patients come and saying, I want an MRI of my back?
Maybe both. You can basically, just so you can Google search, or you can set your terms to get exactly the information you want in your echo chamber. Being pushed back on is part of the human experience, being asked why you feel you need something today versus 2 days from now. And whether or not to the MRI one, I often tell people like you may need one. It's just might not happen today. I had a patient who had come in and GPT was open and was telling them even if your doctor is gaslighting you right now, this is what it said on the screen, you have ways to get the care you think you need. And this was a patient who had a other mental illness, and had been in various EDs multiple times within a 24-hour period. So there's a version where the machines want you to feel happy and feel good, and that's how all of social media and our responsibility as physicians is also to help people navigate the difficulties of sort of the current state, which don't always make you feel good.
Christian, this brings me to my question about the podcast vis-a-vis the title, The Visible Voices. You are clearly a visible voice in the space of AI and informatics in healthcare. When did you realize you had a voice and when did you start using it?
Man, such a good question. I am from a pretty rural area of New York, which is crazy to say, only 90 miles north of Manhattan. A middle child from a pretty rural, like country bumpkin. My nearest friend was 4 miles away. I first began to notice that I had something to say or could say something as opposed to just keeping my mouth shut with my older and younger siblings around college. And then going to New York City and going to a medical school that felt, that wanted people to speak up and engage in small groups and things. And getting that feedback of human social engagement was when I began to find my voice. Quite honestly, that's usually my family members notice something happened, in college. It's one of the reasons I love liberal arts college education and support it wholeheartedly. And then coming to San Francisco and meeting people like Michelle Lin of Academic Life and Emergency Medicine, being continuing to surround myself with other people who are driven and pushing, and then sort of asking not to be quiet or just like go with the flow. It's difficult to do, but it's one of the things that I think you can only do when you're surrounded by other people who are like-minded and make space or push you to actually use your voice, use your language, much like the LLMs, to come up with an opinion, to say it and make it real. And in college, I learned about Wittgenstein's Beetlebox problem, and I always use that you understand the world as you see it, but it's walled off from everyone. And the only way to engage and to help each other understand it is by engaging in communication and using your voice. So I find it's very, very important to be out there doing this. So thank you for making space.
You're welcome. For audience members that want to follow you, your work, the work of the lab, and everything that's going to be coming out in terms of AI and healthcare, how can they keep in touch and follow along?
They can go to our website, stanfordheal.com, which links over to where our blog will be posted or is posted on Substack. And then we'll have a future potential discussion series and things on there too. So yeah, go to our website, follow along. And then we also have a LinkedIn lab space, Heal Lab at LinkedIn.
What does HEAL stand for?
The Human Experience and Augmentation Lab.
The Human Experience and Augmentation Lab at Stanford. Dr. Christian Rose, thank you so much for joining me on the Visible Voices podcast.
Thanks so much for having me.
The Visible Voices podcast amplifies voices in the healthcare, equity, and current trend spaces. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Find me at Resa E. Lewis, MD on social media or visit thevisiblevoicespodcast.com. Find us wherever you listen to podcasts and watch our episodes on YouTube. This podcast is for education and entertainment purposes only. The views and opinions expressed by our hosts and guests are their own and do not reflect the opinions of their institutions. Information shared here should never substitute for clinical judgment or for medical advice. Together, we're making healthcare more equitable, one visible voice at a time.